Right. First of all, I'm Dr. Balamurugan. I don't know many people would be knowing me. I haven't come across this forum until a week ago when Dr. Mithun introduced me to this forum. I'm sorry for that. And this probably was a fresh case just done 10 days back. I wouldn't be having a long-term follow-up to discuss. Probably we can have the discussion based on intraoperative problems that you can face and how to manage it. So I'll be quick considering the time. So, Uncle, this is a case of hip replacement that I've done for a fused hip. So, the challenges that we face in ankylosed hip with altered anatomy and landmarks, and it could be abductor dysfunction. So, technically, it would be a challenging one considering a routine THA. Of course, for any THA, the goal should be to give a pain-free mobile joint with a good function. So this particular patient, she's 73-year-old lady. She's a housewife. She's from Ooty. And she was having a lot of back problems in the past, for which she had lumbar fusion surgery done 8 months back at Kauvery Hospital. And incidentally, she also had childhood hip problem on the right side, for which she had hip fusion. And she was going on well until this spine fusion surgery, where her peculiar function, problem was that she was not able to sit up erect. Like every time she has to lurch backwards to sit after the spinal surgery. That's the only complaint that she had. Otherwise, she was very normal and she was walking about, doing all her activities until this spinal surgery. So she wanted to have something done so that she can sit upright erect. So clinically, it was a fused hip on the right side. Surprisingly, the gait pattern was near normal. There was no big antalgia. And the limb discrepancy was around 1.5 centimeters on the right side, NV intact. So this is the preoperative X-ray. You can see on the right side, it's a fused hip. It's kindly dysplastic considering the left normal hip. Probably because of the fusion that was done
Can we
almost
stop
50
with this
years
and go
back.
for discussion? We can stop with the X-rays and we can go for
Yeah.
how can we proceed?
So this is a dysplastic hip to me. With my interpretation on the AP view, it looks like the femur is smaller than the left, probably a smaller cup that I would expect intraoperatively. And also to be taken note is that the patient is around 5 feet. She's a very short lady. And yeah, I put the lumbar lateral views sitting and standing for preoperative planning. I'll stop there and then we'll have the discussion.
So this is the fused hip and lumbar surgery is done from L3 to L5. And here are the sitting and standing X-rays. So how can we proceed, sir? Anyone?
So the challenges that I'll volunteer. The challenges that I thought I should face intraoperatively was, of course, this is my first totally on a fused hip. So how to do the approaches need to be considered. When I show you the CT scan, you can understand that the proximal femur was fused in an external rotated position and a flex position. And also the difficulty that we will face in previous lumbar surgery is also adding to the problems. So a lot of thoughts to be considered for the approach, how to do neck resection, cup and stem orientation, version and inclination.
Do you have the sacral slopes measured, sir?
I don't have the measurement. I'm sorry, it was just done in the morning, the presentation. But with what we can see on the standing and sitting, the sacral slope increases more than 30 degrees. So it's surprisingly, although the fusion happened 3 levels, still the pelvis was quite mobile.
Yeah, that's exactly what it was. Even though there is 3-level lumbar surgery, so the sacral slope seems to be changing quite a bit from standing to sitting. But the AP view of the pelvis shows almost like an inlet view. So that, but that is not from the spine. Most likely that is from the hip having a significant FFD.
Correct.
Exactly, sir.
Yeah, so I think the hip has an FFD, and that's why the AP view is looking like an inlet view. Other than that, the spine mobility seems to be good, even though 3-level lumbar fusion has been done. So here, I think you can safely ignore spinopelvic parameters and
Exactly.
go with the normal planning for a fused hip.
Yeah.
Spot
Yeah.
on.
So that's exactly what I thought. So I thought, although the fusion happened, still it is behaving like a normal pelvis with a good change in the sacral slope. And you can see the pelvic tilt that happens on standing. So I think we can probably consider a normal acetabular version and inclination.
Yeah, right. So your
Any other thoughts?
Yeah, just to point out, sorry, it's just a 2-level fusion. It's not a 3-level fusion.
2 levels, sorry.
Sorry.
Yeah. I mean, the 3-level screws, but it's a 2-level
3-level
fusion.
screws. Yeah, we are not spine surgeons. Sir.
Yeah, the main thing to be considered is the lumbosacral fusion has not happened.
Yeah, that's what has spared it. And the upper lumbar vertebrae have some flexibility.
Yeah, I think L5S1 has been spared. I think that saved a lot of, and yeah, as you are saying, the upper lumbar seems to be moving quite a bit. Okay, so but again, the external rotation deformity. So, what approach are you planning?
So
Anterolateral,
can I just show you
normal
the CT
anterolateral or
after?
dorsal?
I'll just show you the CT before we talk about the
Yeah,
approach. This is axial view. So it's quite external rotated. You can see that.
yeah, right.
So is there a limb shortening because the acetabulum looks
It's
smaller than
around
the other?
1.5 to 2 centimeters. And the other thing that I was considering is the location of the GT. It was quite lateralized than how a normal proximal femur was would look like. I don't know if you can appreciate that.
Yeah. You're right.
Yeah, I don't think it's only due to the external rotation deformity. It also probably, I know, the fusion that
But
happened.
some amount of valgus of the proximal femur.
Yeah.
Yeah, there's some remodeling of the
Yeah,
happened.
valgus remodeling. Yeah,
angle.
right.
Surprisingly, she was living a very near normal life until this surgery. Even now, her only complaint was that she couldn't sit upright. Probably loss of pelvic flexion on sitting. I don't know what exactly was happening. So she wanted something doing. So I'll move on.
What is your measurement of the acetabulum on the opposite side?
48. I don't have the templating picture.
No, on the CT you can measure on the AP view. I mean the lateral view. I mean the axial view.
I forgot. So if it's such a stable fusion, what is the problem she was having clinically?
So as I told, after the surgery of the spine, she is not able to sit upright. She has to lurch backwards. Her entire torso should be, extended for her to sit. So she's not able to sit at 90-degree hip flexion, which she normally used to do before the spine surgery.
Yeah, I think she was compensating for the hip with the spine.
Correct.
Once they kind of cut down the mobility with that spinal surgery, she is not able to manage now.
Correct.
Yeah, right. Probably if she had a hip surgery before, she might have avoided the spine surgery.
Probably, nobody would have thought about hip problem. So she was complaining of low back pain with radiculopathy, for which she
Yeah,
had.
it's well documented. Patients with the hip fusion and back pain, generally, I mean, there are a lot of studies that have shown that once you correct the hip fusion or take it down, the back pain improves dramatically. So, I mean, it's quite well described. I think that might have been considered before she was taken up for the spine.
Yeah, the first time I saw her was only a couple of weeks back.
Yeah, I understand. I'm saying, I mean, in hindsight, the spine surgeons
Correct.
could have considered the hip.
Correct. This was referred
So
by
the-
neurosurgeons who did the
like
injection.
Fine.
So they had no clue
like
what
you
was
said,
happening. And
this is a fusion which has been done at the age of 12.
yes,
Not done.
Yes, sir.
Spontaneous.
60 years ago.
You said she had some surgery at the age of 12, no?
Yes, sir.
Yeah.
So this is a man-made fusion.
Yes.
Yeah, right.
Probably Perthes, probably Scuffy. We don't know. It was 60 years ago.
Sir, we'll proceed, sir.
Yeah.
So preoperative planning would be to find the true acetabulum. We need to have landmarks. I thought sciatic notch, tail, and operative foramen ischium should be a landmark for me to guide in the acetabular socket placement. Of course, the bone stock should be considered. Considering the CT scan, I was a little worried about the femoral canal morphology. So I had backup of corail and distal loading stems. Ultimately, socket version and the combined version. So I chose to go. I normally go posterior for all my hip patients. So I didn't want to change my way of looking at it. Although I knew that since the proximal femur was quite externally rotated, it's going to be difficult for me to do the neck resection. So I considered the dual approach for this particular patient. I wasn't thinking about too much of soft tissue release in this patient. As I told, implant selection, I didn't uh, consider any problems in the acetabular side, but for the femoral side, if at all my neck resection was not good, and if I violated the calcar, probably I should have gone for I should go for a distal femoral loading stem, like a Radial or a Reclaim or a Wagner stem. So I had backup for those stems. And if I'm too worried about the version, probably I should have gone for a S-ROM. So these are the thought process that I had before the procedure. So this is the intraoperative picture on the left side with complete internal relation with whatever I can to see the neck profile just before the positioning of the patient. And on the right, you can see the intraoperative picture. The femur was, I don't know whether you can appreciate, it was quite external rotated. On the right, you can see the gluteus medius. So I went for dual approach. Anterior neck resection was done between the gluteus medius and the lateralis after exposing the capsule. And then after doing neck resection, then I could use a shank spin on the proximal femur in the GT level, and then rotate the proximal femur internally. And then I went on to do a regular posterior approach, taking down the short external rotators on the capsule in toto. And I had CM intraoperatively to see my landmarks for the acetabulum. It worked both ways. This is the first time I'm using CM for my toe lips. So I wasn't really oriented to what was happening. So after a point of time, I gave up CM and then I started doing reaming like how I normally do. One thing I should have done intraoperatively was I thought TAL should be a guiding factor for me, but unfortunately I couldn't chase down to the TAL intraoperatively. So I used the other landmarks for my cup version and orientation. So this is before positioning the patient. Do you want to go? Table down. I'll move on.
Yeah, can you run through this a little bit
Yes, sir.
quicker?
Yeah. So finally, I used a Gription cup 4-6 size with a 6 coral stem. It's a minimum stem that I had. Considering the stem morphology, I mean the canal morphology and the patient's size, I wasn't surprised that it was only fitting into with a 6 coral stem with a 28 head. Although I wish I could have gone for a bigger stem. So this is a postoperative X-ray. Probably my inclination was around 30 degrees, less than to my liking. and the cup could have gone a little more inferior. And I managed with the core rail. However, in retrospect, I thought probably I could have used a distal loading stem just in case.
Probably a stem like Cone Wagner.
Probably. The calca was good, although post-operative X-ray, it looks dicey, the calca. The only problem with the Wagner is, I think it starts with 15. So it may not fit for this particular femoral canal.
Actually, 15 is not at the lower portion. It's, most of the time Wagner fits in where these stems are not able to fit in. So Cone Wagner does quite well. But the
Okay.
15 is not at the tip. Tip is only around 8 mm or so, 8.8
Alright.
if I'm right. So
Okay.
15 is not at the tip. But this looks nice, I think, very nicely done. And I think here Corail has done has come out quite well. So I don't know about the sizing. Maybe, I mean, it depends on the intraoperative foot. Very difficult to comment based on X-rays. But here I think a metaphyseal stem would do pretty well unless there was a version problem.
Yeah, I had a
cup
backup of
also-
Estrom, but I thought Corail was doing the job, so I didn't bother to switch to Estrom. And yeah, I tried size 7 Corail, but it was never going. I even dreamed the distal canal.
After 6, it's 8. Yeah.
Sorry, yeah, the next size maybe. So it didn't really fit. So I stopped with 6 and
I'm
at
sure.
20.
Probable. Yeah, I mean, it's very easy to say on X-ray. It looks. There might be space looking, but the metaphyseal bone might be quite tough for you to crack with the next size corail. That can happen intraoperatively. I think if it is having a good fit intraoperative, I think that's what makes. That's what counts rather than how it looks on the X-ray.
Stay with that because all this remodeled femur is not like the usual femur. All new bone forming intramedullary is quite different.
And as you said before, I think that GT, looks pretty lateral, and I think that's how it was. It has remodeled, like what Ajit sir was saying. It has probably remodeled like that. So I think that's a nice thing to note, and I'm sure she'll do well. I think that's how it looks like. Yeah.
That looks good.
And the pelvis X-ray looks as less like an inlet view.
Yeah, right.
So nice case. We had 2 discussions, sir, the spine fusion and then fuse tip also taken.
So even now she's still struggling to sit upright. This is only a second POD. But I just heard from the physio just before this talk that now she's able to sit upright. I think I'm achieving what she wanted.
It will take 3 to 6 weeks.
So it will take at least 2 weeks, 2 weeks to 3 weeks to sit upright.
Right,
And
now
then
it's 10 days following the procedure.
It will take
I was
some
talking
time.
to Mithun just before the procedure in the meeting that we had in the Ramchandra.
So before the case itself, we decided to present it.
Yeah.
This I'm sure she'll do well. I think it will give a lot of comfort for her. As I said, it will ease the strain on her back also. So.
Thanks, sir. Thanks.